we've been talking a lot about brain metastases as, a group, and obviously there's a huge difference in terms of behavior of melanoma versus breast cancer versus lung cancer for the primary tumors, and even the metastatic disease in the liver and things like that. So I'm curious to know, for something like LIT, all of these radiation oncology trials tend to group, different disease types together. And I'm curious to know if there are certain histologies where these techniques work better. You mentioned, the reason I brought up is you mentioned you weren't sure whether this was really going to work in metastasis. Maybe it'll work in prostate, but it may not work in breast. So I'm, curious to know, we're excited about, creating a CNS metastasis program, but, what are the limitations of how much we can group these things together?
So I'll touch on the imaging piece. I think you're 100% correct. It's unfortunate that we do group these things together. Many of the imaging tools that we have are rooted in delivery to the tissue. And we know that, I can tell you, at least based on anecdote, that vascularity varies widely between these lesions, even when you look at something as basic as contrast enhancement. But if you start looking down at perfusion, there's different changes. There's differences in perfusion between, across cancers, and I'm sure also even within cancers. And so this is an issue, and I think I'm happy to sort of have that conversation and think through that, but I don't have a good answer for you, other than I think it's an important recognition for us in the field, for sure.
And I think that same goes, oh, sorry, I just was going to ask about, for if Manish is here, if he can comment on, the, LIT in one tumor type versus another. He's still here.
I think Manish stepped out.
Okay.
There isn't individual data looking at LIT with particular subtypes, but I think what we'll find, even with focused ultrasound, even when you're looking at blood-brain barrier penetration, again, there's great variability and heterogeneity among different types of primaries, even different types of the same cancer. And so I think as we move forward, we probably have to be more mindful of how we design trials and not lump all metastases in one. But I think we're still learning how to best do that.
I guess, Marisa, if I could ask you a question on your talk, and then Javier's afterwards. But I want to ask you, I guess, as support for Adil and for your comments, in that I think we understand that it's not only the blood-brain barrier, but also the CSF is just these fenestrated pathways that are just hyper integrated with one another. And so I think that, if we're to use intrathecal administration, it could prove to be beneficial, but there would still need to be, a focused ultrasound. So I guess the question I wanted to ask you is, with the Meng study, as well as your study that you will be performing, I wondered what the potential patient criteria would be. So for example, we know that it's going to be like a localized region for the focused ultrasound, but are these patients going to be treatment naive, as well as, are there other criteria, such as if the patient may have like other cofactors, such as, they might have meningitis or perhaps other types of, inflammatory types of microenvironments, to the point where you might want to exclude them in terms of if they might confound some of the responses?
Yeah, that's a good question. And for the focused ultrasound study in non-small cell lung cancer patients, so it is going to be a very specific group of patients without leptomeningeal disease. And they have to be functionally, they have to meet a certain functional kind of standard, right? Like I would say like all of our clinical trials. And so they can't have concurrent infections. They can't have concurrent, medical issues aside from, a new diagnosis of lung cancer with concurrent brain metastases. These will be treatment naive patients. So it's at the time of a new diagnosis. So it is, one of, I think, and Michelle can speak to that too, one of the challenges, I think, of designing trials for patients with brain metastases is we try and create a pretty homogeneous cohort of patients that we're looking at, but then you run into issues with enrollment, right? So it's kind of this balance of how do we design a study that's broad enough to enroll patients, but also where we can actually learn from the results.
And,
Yeah.
and I guess one additional question for you as well. Do you know if in the literature with focused ultrasound, I mean, we see with the MRI that after a while, it seems like the blood-brain barrier then closes back up again. But is that due to just the flexibility of the blood-brain barrier just coming back into its original form? Or is it, there's ultrasound itself might break down certain areas or, like some sort of damage, and then it just repairs itself after a while?
I think it's a transient mechanical disruption of the tight junction is really what it is that then restores itself.
Okay.
There are likely some effects in the surrounding microenvironment, but it's really transient effects on that and on those endothelial cells.
Thank you.
Yeah.
There's a question from so James Rubenstein asked, in phase 1 investigations, we reproducibly detected interparenchymal responses of refractory CNS lymphoma in less than 2 centimeters to intraventricular rituximab or rituximab plus methotrexate, suggesting some brain penetration of therapeutic agents. Why not study combined IV with focused ultrasound delivery of therapeutic agents?
I think that's a great question, and I think that's where eventually this will go. The study is designed looking at monotherapy, particularly get safety data, essentially. But the goal is then to look at it in combination therapies, and so I think that's eventually where this will go in terms of future studies. And even within this particular study, we've been having discussions of expanding for a combination therapy.
Just sending to the audience that's at home by video that they can send in questions via chat as well. I'm monitoring the chat.
So I have another question for Javier. Could you elaborate a little bit more on the automation process for detecting lesions? Is it due to like a threshold on the contrast, or is there like a classifier that's going to be trained on, a previous data set in order to get more accurate in terms of detecting positive lesions within your images?
Yeah, it's a great question. So it's a deep learning model that's trained on multiple radiologist gold standard or multiple radiologist lesion segmentation as gold standard. It is set up to be updated with any, if they're. So I'll tell you what we're doing with the glioma segmentation, which is coming online, I would say, within the next quarter. And then this would be something that would follow. With glioma segmentation, the plan is to have a routine standing review of misses, of false positives or false negatives, and then take the resegmented tumor and use that to continue to train the model. So yeah, that's it would be a similar paradigm with brain metastases. Yeah.
I see. And then it would just be like a comparison with clinical fellows with, manual in terms of what's the Pearson correlation in terms of their ability to say, how accurate the training model is, right?
Yeah, that's exactly right. Yeah, exactly. Like unfortunately, the best gold standard is still human review of the imaging data. Yeah. Yeah. And so one of the things we found with this was that there were certainly some lesions that were more readily detected by the model that on human re-review were like, oh yeah, that's a real lesion. Some of those ambiguities are resolved or improved when you factor in things like the 3D spin echo imaging that I mentioned, the space, which is Siemens's term, and then Cube, which is GE's term. Vista is Philips's term for what it's worth. When you factor that in, lesions that are small at the periphery near blood vessels, that certainly improves lesion detection as well. So I think that's going to also assist in improving its performance.
Thank you.
Comment on how that might be used for how will you encounter differentiating radiation related or treatment related changes when using automation?
Yeah, it's a great question. So some of the things we're thinking about are our rate of change. So one of the ideals or one of the ideal states we're chasing is to build this into packs so that you can have lesion tracking with this. And certainly the new packs that we're using, Visage allows this. It's very clunky right now. It's kind of manual, but we're getting access to, I forget what it's called, but it's essentially their back end so that we can port these types of systems into packs. And so I think the first step is going to be to really be able to track, to identify, okay, which lesions have been treated and follow those over time, and then identify new lesions. And then for the lesions that have been treated, you can imagine segmentation is really the first part to any downstream image analysis. And that means, if you want to look at whether, what the perfusion is, you need to have the segmentation first. And so you can look at perfusion within the segmented tissue. You can look at susceptibility within the segmented tissue. You can look at those ratios that we talked about, edema versus enhancement. So it really unlocks a lot of future potential if we can have that very first base step of the segmentation, because then it's a matter of just aligning the images and then drawing whatever quantitative data we want from that. So I think there's more to come, and where we are right now is we're kind of getting these things, ironing out these kinks within the glioma space, and then once that's there, I think this will fast follow. Cool. Thanks.
I was wondering if lit or thermal ablation, because he showed that there was a slide on how with thermal ablation that you would increase necrosis around the surrounding areas for tumor antigens, as well as more of an immunogenic type of response. And I'm wondering if this is very similar or perhaps quite different than, cryoablation types of therapies. Like, is this, I'm not really sure about the literature, so I was just wondering if there's the stark contrast between the two different types from hot or cold sort of a scenario. Because I've also seen from cryoablation that you also form, these icicle crystals and balls that allow for a more necrotic area in terms compared to the outskirts, which is apoptosis.
Yeah, my understanding is, so I don't know of any cryoablative procedures that have been used in the brain or that have been studied in the brain. I wouldn't be, so just like with focused ultrasound, I wouldn't be surprised if there is some parallels in terms of immunomodulation of different techniques. We see it with radiation, we see it even with surgery, so there probably are some parallels between the two technologies. We don't have a comparison